Hello, everyone, and welcome to the Cochrane Neurological Sciences webinar. I am Kathy Mahan, the coordinator of the Neurological Sciences field, and I want to introduce you to Dr. Teresa Cantisani, who is the director of the Neurological Sciences field.
Hello, everyone. It's a great honor and a pleasure for me to introduce Professor Peter Sandercock, Emeritus Professor of Neurology at the University of Edinburgh. The best academic and clinical neurologist is here with us today to talk about why and how to read a Cochrane systematic review. Professor Sandercock was coordinating editor of the Cochrane Stroke Group for over 10 years, and he was chief investigator of mega trials in acute ischemic stroke. IST1 and IST3 were large pragmatic trials which have had the honor of participating as a blind assessor in Italy. Thank you, Peter, for accepting our invitation. Please.
Different hospitals around the UK, in Stoke and Manchester. And I was immediately struck as I moved from one hospital to another, how treatment changed between hospitals. And the particular example was the percentage of patients with acute myocardial infarction who were treated with anticoagulants and thrombolysis. And in Stoke, none of the patients admitted to the coronary care unit received either anticoagulants or thrombolysis in those years. Whereas when I went to Manchester, one senior physician treated all of his patients with oral anticoagulants, but the other physicians, some used no anticoagulants at all, and some treated about half their patients with anticoagulants. And I was really surprised by this. Why were all of these expert doctors doing things differently? And which of them was correct? And what should you do if you didn't know what to do, or if you were uncertain about the value of a particular treatment? But the other thing which was difficult was if you spoke to your boss and said, well, why do you treat all your patients with anticoagulants? The boss would say, well, because they are effective and safe. And you'd say, but hang on a minute, in Stoke-on-Trent, we never treated anybody. And so many experts didn't like that, didn't like a junior doctor to challenge their opinion. So this was the era of opinion-based medicine. And I became interested in how to challenge the authority of these senior figures who were very certain about what they were doing, but without any evidence. So in 1988, I moved to Edinburgh. And the question that I was very interested in at the time, as was Stefano Ricci and Teresa and all her colleagues in Italy, was if you have a patient with an acute ischemic stroke, should you treat with antithrombotics, heparin and aspirin, yes or no? And there was a lot of debate. Some people were very, very certain about the value of anticoagulants, and there wasn't a lot of interest in antiplatelet agents. So we then began to think about, well, was this an area for a clinical trial? And so we started to look at the clinical trials, and they were very variable methodological quality. Some seemed to be positive, showing benefits of reduction in deep vein thrombosis, others showing no effect or negative or harm. There were quite a lot of trials, but only some of them were often cited, and that tended to be the more positive trials. And then we discovered there were some trials that were completed, but not published. And all the trials were small. None of them had adequate statistical power to give a precise answer, a precise estimate of the effect of treatment on death, intracranial hemorrhage, and long-term disability, all things that we were very interested in if you're going to test a treatment on 15 million, or give a treatment to 15 million strokes a year worldwide, because that's the size of the problem. So the first thing you need to take into account is random error, or the play of chance. So if you have small sample sizes, the chance of random error as an explanation for whatever observed effect you get is large. And that means you end up with a wide confidence interval and uncertainty. So if you have a large sample, you have a narrow confidence interval, and then that is the same as a precise estimate of treatment effect. But then there's also bias, because bias is a systematic error, meaning that on average, if bias is present, if you keep doing the experiment or the trial or replicate it several times, you will systematically reach the wrong answer, because whatever bias factor is present is pushing you in one direction or another. And if we then look at the trials that had been done on antithrombotics for acute stroke, well, they were of poor quality, so they were unreliable. Only some trials were cited, so that's publication bias. Some trials were completed but not published. None of the trials were adequately powered, and so the effects on death, intracranial hemorrhage, were all prone to random error. And so an answer to all of these problems is to make a systematic review of all of the relevant trials to try and avoid bias. And then by getting a larger sample, you reduce the chance of random error, and you end up with a better chance of understanding whether the treatment works or not. So if we look at what was available from a systematic review in 1993 of the randomized trials of anticoagulants in acute stroke. So the trials here in this top group were trials of unfractionated heparin given subcutaneously for DVT prevention. But this is the effect on death. So here was a trial that suggested an increased chance of death, this one a reduced chance of death, and a systematic review, a meta-analysis of all the trials, suggested that anticoagulants might reduce the risk with low-dose heparin, might reduce it by 30%. These were trials of of low molecular weight heparin, and again, very wide confidence intervals, tiny numbers of subjects, but these suggested an increase in mortality, but again, with very wide confidence intervals. So across all of these, you can see that immediately the confidence intervals are much narrower, but they overlap the line of no effect. So this result here suggests anticoagulants might reduce the risk of death after acute ischemic stroke by a little bit, or by quite a lot, or might increase the risk of death. So really, at the end of all of that, the systematic review says we still don't know. As for antiplatelet drugs, there were no randomized trials in the acute phase of ischemic stroke. So one of the important things about a systematic review is you can try and draw conclusions for clinical practice. And from those data, it's obvious there is no clear indication to use either anticoagulants or antiplatelets in this context of acute ischemic stroke. But also from a systematic review, you can draw indications for research. Well, there was obviously a need for a large-scale trial sufficiently powered to reliably estimate effects on death, because stroke was the third most common cause of death in many countries worldwide, and more importantly for the patients, survival free of disability, which is what matters to the patients. And none of the trials had measured that before. So a systematic review had given us a lot of information. It told us it was ethical to do a trial. It told us the trial needed to be large because the risk of death was low, or the risk of hemorrhage was low, and therefore you need to recruit a lot of subjects to get an appropriate number of outcome events. And so that led to the two mega trials, IST, which tested aspirin versus control, and in a factorial design tested 2 doses of heparin versus control, and CAST in China testing aspirin versus control only, just in China. And between the 2 trials, they randomized 40,000 patients, which was a large enough sample to provide a really reliable estimate of the effects. And the conclusion was, as we all know, aspirin was simple, effective, and affordable for use in acute ischemic stroke worldwide. Anticoagulation with high-dose unfractionated heparin had no place in acute stroke treatment because of high risk of bleeding, and the place of low-dose heparin or low molecular weight heparins was debatable, and there's still some debate continues about exactly what their role is. So that's some reasons for doing a systematic review. But what then happened was that there was an absolute information explosion, an exponential increase in the number of control trials in stroke. And so how on earth do you control, how do you keep up with all of this? And as of the 8th of January this year, the Cochrane Stroke Group Register includes 34,000 reports of controlled trials in stroke. That's 34,000 reports from 13,000 individual trials. And of course, since the 1980s, people have done a lot of systematic reviews. So this Cochrane Register includes over 2,000 systematic reviews of treatments for stroke. But the Cochrane Stroke Group focuses on high quality reviews of high priority topics. And there are just 209 Cochrane Stroke Group reviews, so covering many areas of stroke medicine. So in a way, a systematic review is a solution to that massive explosion in evidence and information. Because as doctors, health professionals, nurses, physiotherapists, everyone is very busy. No time to read all of those trials or even to find them all. And so a systematic review provides a convenient summary of all of that evidence on a particular topic. And of course, as from a methodological point, it reduces bias in the estimate of effect. And because it will assemble a larger sample than one individual trial, will be associated with less random error, give you a more precise answer and less uncertainty. So the next question is, if you're going to do systematic reviews, well, why Cochrane reviews? Well, Cochrane has always focused on methodological quality. And that, I think, is as important in individual clinical trials, that they are methodologically rigorous. And it's equally important in systematic reviews, that they are methodologically rigorous. They should include a comprehensive search strategy to find all the trials, unpublished and published, to try and reduce publication bias. There's evidence, external evidence, that Cochrane reviews are less prone to in what you might call an industry bias, that is, in favor of a particular pharmaceutical product or device. And we've all seen famous speakers who've been paid a big fee by a drug company to give an important lecture at a conference. And I've seen very distinguished people give a completely biased account of some new drug, and because they know they've got to say something nice about the drug. And so Cochrane reviews try and reduce conflict of interest and to reduce bias towards or against a particular product. Of course, statistical methods are important, and statistical methods are moving quickly. And so the Cochrane process always ensures that the most up-to-date and appropriate methods are used. So now you have a question and you want to read a Cochrane review. So you need to decide, is your question about a very specific treatment, or about a more broad therapeutic area, or about a diagnostic test. Whatever your question is, it's helpful before you start reading to think about, well, what sort of patient am I talking about? What sort of intervention am I thinking about? What drug, what dose, or what operation, or what device? And what do I want to compare it with? Do I want to compare it with no treatment? Or do I want to compare it with adding it to an existing standard treatment? And what outcomes am I most interested in? Is it death, or is it disability, or is it some other kind of event or quality of life? So going to a non-stroke example, let's think about a 70-year-old man who presents with some difficulty speech, and you have a scan showing that he has a glioma. And his family asks you, the doctor, would chemotherapy extend his survival, but allow him to maintain his quality of life? Quality of life is very important, especially as you get older. So the intervention is chemotherapy, the comparator is no chemotherapy, and the outcome is survival and possibly quality of life if the data are available. So let's search the Cochrane library for a relevant review. So here's what you see if you search the Cochrane library, and up here you'll see there's a search box where you can do a simple advanced search, or you can click on this box here and you can search for a review by an author, depending on a keyword, a review done by a particular Cochrane group, or on a particular Cochrane topic. But what I used was an advanced search to look for glioma. So I used the mesh descriptor glioma, and here we are, we've got 20 systematic reviews relevant to glioma. I'll start with this one. Now this one, Cochrane reviews are periodically updated. This one was last updated in 2002, chemotherapy for high-grade glioma. And you might say, well, why on earth would you read that? Well, because that was done at a time when there was, the treatments were compared with control. So if our comparator is control, this is the review that's relevant. And of course, since that review was done, trials have changed. So we'll look at that one, but we'll then look at this more recent review, updated just last year, on newly diagnosed glioblastoma in the elderly. So this is much more focused on our elderly 70-year-old patient. And this is a more complex network meta-analysis of all of the potential treatments. So this is, for many questions, the simplest thing to do is just to read the abstract, because that's all of the information that you want to get quickly. So in a hurry, go to the abstract of the Cochrane review. And if you, wherever you are in the world, you can always get the abstract of a Cochrane review for free. There's no cost. In many countries, the whole review is free to access, but for everyone around the world, the abstract is always free to access. So for this review, we want to compare radiotherapy plus chemotherapy with radiotherapy alone. So radiotherapy was the standard care, and adding, so this is an unbiased assessment of chemotherapy. So the only difference between these two treatment arms is chemotherapy and no chemotherapy. And this is patients who've already undergone surgery and with a high-grade glioma. So in 2002, 12 trials had been completed, including 3,004 patients. Chemotherapy significantly reduces the risk of death by 15%. Very significant. You say, gosh, that's amazing. But what's important about Cochrane reviews is that they look at different ways of describing the treatment effect. So 15% relative reduction sounds quite big, but what you immediately see is that in the radiotherapy, surgery and radiotherapy alone group, only 40% survived to 1 year, and that increased by 6% to 46%, so quite a small difference. Or only a 2-month increase in median survival time. So half the patients survived 2 months longer. Now that's a very small difference. And these trials provided no data on quality of life or on toxic adverse effects. So that tells us that chemotherapy does something, but it doesn't really tell us what we should do with this 70-year-old man with a high-grade glioma. Should we give chemotherapy? Is it worth it? Yes or no? So now we'll go to this more complex network meta-analysis published in 2020. Sorry, it should be 2023. So this was to determine the most effective and best tolerated approaches for the treatment of elderly people with newly diagnosed glioblastoma. So these are the patients we're interested in, just like our own patient. And to summarize current evidence for how much resources it would use, utilities, that's quality of life, cost effectiveness with these different treatments that are now available. And the method is a much more complicated network meta-analysis. And I just want to highlight how complex it is, because this will help you read the review. So it's assessing lots of different treatments at one time. There are a lot of pairwise comparisons comparing each treatment with another one. There aren't many network meta-analyses in the Cochrane review. If they're correctly performed, they can be very helpful to compare different treatments that may not have been directly compared within an individual trial. But you can see these are pretty complex analyses. So if it's complex, try and go to the plain language summary, which every Cochrane review has, because that's, if you like, that's putting all of that complex statistics into something that you can understand. So chemoradiotherapy prolongs survival. Yep, we know that from the 2002 review. Serious adverse events affecting blood components are more common with anti-cancer medicines, TMZ and BEV, right? Okay, so that's one concern. And they've decided, they've concluded more evidence is needed, excuse me, on how different treatments impact quality of life and costs. So that's, again, a sign that we still don't have a clear idea of the best treatment. And also in trying to select patients, age alone is unlikely to be the best determinant of the optimal treatment of older people with glioblastoma. So I think what we have is that this network meta-analysis boils down to continuing uncertainty despite all the statistics. However, if you're reading a Cochrane review, you may want to go into greater detail. And so these are the components of a Cochrane review. So there's an abstract, a plain language summary, author's conclusions, that is implications for practice, implications for research, and the summary of findings. And that's what we'll put up here. So the summary of findings, you'll have one of these for each of the outcomes which the review has looked at. So this review has looked at various outcomes, and here this particular table shows you the effect on overall survival, comparing different interventions with the reference one, which is radiotherapy. So lower dose radiotherapy compared to that has less effect, and so it's less effective. And the quality, the certainty of the evidence using the grade method to evaluate the, as it were, the total quality and reliability of the evidence. So this is low quality evidence. And so what we can see is that even though many more trials have been done, we still don't have really strong evidence to choose the best treatment. But you might say, okay, well, I just really want to sort out a particular comparison for this particular patient. So you can go and look at the figures and tables. So if you click on that, you may see this sort of thing. So you can go to the forest plots, and just remember again that if you focus too closely on numerical data, you may overlook important clinical contexts. So if we look here at chemotherapy versus radiotherapy on progression-free survival, there really is no effect. If anything, it's slightly in favor of not chemotherapy. And when you compare chemotherapy versus radiotherapy in relation to adverse thromboembolic events, then clearly chemotherapy is associated with higher risk of thromboembolic events versus radiotherapy. In other words, favoring radiotherapy. So this is why you can get too confused by the detail. So in summary then, for glioblastoma, these two reviews tell us that the 2002 review is still relevant because it's a comparison with control. The 2020 review and network analysis, the clinical focus is on an important area of uncertainty, glioblastoma in the elderly, and it compares recent trials of treatment, but there appear to be minimal gains in survival and uncertainty about the effect on quality of life. And so, for example, if your elderly patient therefore decided not to have chemotherapy or not to have any additional treatment beyond surgery and radiotherapy, you could say, well, that's okay. You know, there's no clear evidence that by having chemotherapy, your life will be better. So that's thought about the treatment of a very specific disease, glioblastoma, in an elderly patient. But Cochrane reviews are also available, which look at a broad therapeutic area. And the question I thought would be interesting to look at this type of review is how best to improve impaired upper limb function after a stroke. So if your arm is paralyzed by a stroke, particularly your dominant arm, that has a huge impact on your quality of life, your ability to live independently. So this is, again, in terms of stroke rehabilitation, this is a hugely important area, both for the patients and trying to do research to find better treatments. So there are a huge range of treatment options for improving arm function after stroke. This is just a picture of some of them: constraint-induced movement therapy, mirror therapy, transcranial magnetic stimulation, robot-aided repetitive task training, and so on and so on. There are many different treatments that we could evaluate. So if you've got a patient with an arm and you really want to improve their function, you might read this review to guide what treatment to use. Now, when you look at a very broad therapeutic question like what can I do to improve arm function, that's called a Cochrane overview. And what a Cochrane overview does is looks at all potential interventions and to synthesize evidence from systematic reviews, whether Cochrane reviews or non-Cochrane reviews, and where relevant individual trials, of interventions which were tested to try and improve upper limb function after stroke. So Alex Pollock and colleagues assembled this overview, and they identified 40 reviews of the topic improving upper limb function after stroke, 19 Cochrane reviews, 21 non-Cochrane reviews, and 18 individual different interventions were included. And of course, some were tested, the same intervention was tested at different doses or intensities and in different healthcare settings, domestic, at home, or in outpatient clinics or inpatients. So the reviews in total included over 500 clinical studies with 18,000 participants. So again, a large and complex review, and particularly important if you were trying to decide your hospital policy or your what you should persuade your administration to invest in for rehabilitation of stroke. So the authors conclude, there are many overlapping reviews on how to improve upper limb function following stroke. So there's been a lot of research. And their conclusion was this review can guide clinicians and policymakers to the relevant systematic reviews to support clinical decisions for individual patients, but also clinical policies. And it provides a single, accessible, comprehensive document that brings together all the relevant reviews. So it doesn't tell you what to do, but it provides all the information you need in a consistent format to reach decisions. And here it is. So this is everything that you might want to know. Bilateral arm training, biofeedback, brain stimulation, constraint-induced movement therapy. And for each one, it tells you what it does for upper limb function, upper limb impairment, and activities of daily living. And then there are notes describing the overall, just some general comments about it. And so this also gives a grade of the evidence. So O is moderate grade evidence of no benefit or harm. Plus is moderate grade evidence of benefit. Minus is moderate grade evidence of harm. So bilateral arm training appears to have some harm on upper limb function and ADL and no effect on upper limb impairment. So this conclusion there is moderate quality evidence that unilateral arm training is more effective than bilateral arm training. And here we've got robotics, 2 positives, beneficial effects on the Fugl-Meyer score and ADL measures. Moderate quality evidence of no benefit or harm on strength. So again, quite a mixed picture. And you can, as it were, here's a fantastic resource to answer your questions about how to improve upper limb function after stroke. And I'd like to finish now with a brief thought about diagnostic tests. And of course, in the time of COVID, a diagnostic test that's particular interest is rapid point of care antigen and molecular-based tests for diagnosis of SARS-CoV-2 infection. And there's a Cochrane review of this that's available. And as you're all aware, there are all sorts of point of care tests for SARS-CoV-2 that might be used in the emergency department or in primary care or even in your own home. The main thing is that they should be rapid. And to assess the diagnostic accuracy of point of care antigen and molecular-based tests to determine if a person presenting in the community or in primary or secondary care has current SARS-CoV-2 infection. And this is a pictorial summary. So the evidence that was assessed was 18 studies comparing rapid point of care tests to RT-PCR reference standard. 8 different commercial tests were assessed, 4 antigen, 4 molecular, and a sample of about 3,000 patients, of which 1,700 were confirmed COVID. Now, these were largely what were remnant lab samples. So this was going to a lab and testing samples that had already been collected. And that's not reflective. So that the Cochrane review makes a very strong point that this is not the way that the tests will be used in the real world. So that's one caveat to bear in mind. So for the rapid antigen tests, there were 8 test evaluations in 5 cohorts. And so it had about a 56% sensitivity and a 99% specificity. But the sample size was quite small, so the confidence interval is quite wide. Testing the genetic material of the virus, again, this is a rapid molecular assay, 2,200 samples, 13 test evaluations. again, high sensitivity and specificity, but you must remember that these are again remnant lab samples. So not collected in a prospective way in a representative population of people presenting to accident and emergency departments or to primary care. So the limitations, 13 of the 18 studies had unrepresentative populations. Most studies were at high or unclear risk of bias, and 3/4 of the studies did not follow the manufacturer's instructions. So when this was published, it was clear that more prospective and properly conducted comparative studies were urgently needed. So the conclusion was rapid tests have the potential to be used to inform triage of RT-PCR use in symptomatic cases, but the evidence is not strong enough to determine how useful they are in clinical practice and in whom they should be used. So, and of course, that puts all clinicians in a difficult position. So let's hope that this can be updated with the evidence that's been accumulated since this was written. So in summary, Cochrane systematic reviews are methodologically sound and provide a reliable summary of the relevant evidence. You may find your information on your particular question in a single review or in several related reviews, or for a very broad topic in a Cochrane overview. In many cases, if you're in a hurry and you have limited time, the abstract and implications for practice and will answer most of your clinical questions very quickly. And after that, you can rapidly choose which additional parts of the review you need to read to get the information that you need that is relevant to your research or other question, excuse me. But I think in summary, we can say that the Cochrane Library is a treasure chest of information. And as I said earlier on, the abstracts are free to all. And in many countries, your institutions will ensure that you can have free access to the full Cochrane Library. And if they don't, then you perhaps might ensure that they get a subscription so that you can access all that's available in the Cochrane Library. So on that note, I shall thank you for your attention from a wintry Edinburgh, and I'll stop sharing my screen and we can go to the Q&A. Oops, stop sharing, there we are. Right. So
thank you very much, Peter, for this wonderful and extremely clear presentation. As usually, we were aware of the fact that when you present something, it completely appears clear to our listeners. And you are so able to simplify difficult things so that even we poor old neurologists of the countryside of Italy can understand it. Thank you. Now, it's open, your presentation is open to discussion.
I see there is a question from Danilo Toni.
Yeah.
He says, many Cochrane reviews end by saying there is no evidence that, and he quite reasonably points out, unfortunately, many people interpret the absence of the evidence of an effect as the evidence of an absence of an effect. And this is absolutely the case, that when you have a very wide confidence interval, and I'm going to cheat and share my screen and go back to the first slide, hang on. Oh, hang on. What? Quick skip back to right to the beginning. Bear with me. Okay. So this, I think, is the perfect illustration to Danilo's point. So this is, there is no clear evidence on the effect of anticoagulants, and that's because the confidence interval overlaps 1, and that equals uncertainty. So there is no evidence of harm, there's no evidence of benefit, there's just not enough evidence. And so I think that's it's a point that we keep needing to make. So if you can say there is no evidence of benefit, you can then look at this and you can say, but hang on a minute, the overall estimate is a 14% reduction with anticoagulants. So we cannot exclude a benefit. So the reply to Danilo is, if there is a wide confidence interval that overlaps the line of no effect, you cannot exclude benefit, but also you cannot exclude harm. And that was the important point in trying to move this forward. So that says we could do further research to try and answer this question. Does it cause harm or does it cause benefit in terms of death? So that's my reply to Danilo.
Okay.
So we have another question from Kevin Pacheco Barrios. 2 questions about Cochrane Systematic Review's update process. He asks, number 1, how can we decide the appropriate time for a Cochrane Systematic Review update? In your opinion, the living systematic review will replace the way Cochrane is performing meta-analysis? That's a really good question, because updating reviews is a lot of work. It's a huge job. You have to sift through you have to search, you have to sift through the evidence, and sometimes that's just beyond what somebody can do, an individual, and you may need a team of people. And if you've done a review, a big review, it's quite difficult to reassemble the team. So it's a practical issue. I think I would point out that some reviews, the question is no longer relevant. If you like, antiplatelets for acute ischemic stroke, antiplatelets versus control is no longer a question. And therefore, there's no point in updating that review. You need to do a new review. Well, is it more intensive antiplatelet therapy versus less intensive? So sometimes not all important reviews need to be reviewed. So you need a process to choose which reviews to update. And a living review, there are ways now to create living reviews. And this is being done a lot in the context of developing new treatments for diseases like motor neuron disease, multiple sclerosis, where you're trying to repurpose old drugs or find new drugs that work in other areas of neurological or other areas of medicine that might have a plausible effect. And so there are various groups working on living reviews of all of the available animal and experimental data combined with available clinical data to try and choose interventions for these, for neurodegenerative diseases that are continually being updated, so that when you come to start a trial, you've got really promising treatment. So living reviews, I think, are coming. Quite what place they will have in the Cochrane collaboration, I couldn't give you an answer, but they're certainly a very interesting area. So I think I've answered the second question, is when could we stop the update process of a specific question? Well, one, I did the systematic review of antiplatelet agents, and we said, we're not going to update it anymore because there are going to be no more comparison trials comparing antiplatelet with no antiplatelet in acute ischemic stroke. And then I retired. And so that was 2 reasons. The team retired and the question kind of became irrelevant. For other questions like the glioma question, well, clearly the treatment of glioma is going to go on, but again, the question may change. And so the same group that did the first review, Leslie Stewart, has moved on to other questions, and Robin Grant led the most recent network meta-analysis with a much bigger team. So I think as time goes by, the question changes, and so the structure of the review will change. So it's a bit different.
There is another question. How many clinicians do you think actually use Cochrane reviews in everyday practice?
Well, I think what tends to happen is that the answer is probably not many, because, you know, Cochrane reviews are big, you know, it takes a while to read them, but they tend to feature in guidelines or get summarized in very short documents. They start to appear in textbooks. So the conclusions of Cochrane reviews appear in all sorts of important places, but I don't think it's, well, I mean, Stefano, in your clinical practice, did you on a ward round get a Cochrane review out to decide what to do with an individual patient?
No.
You might go and look at a Cochrane review after you've been round the ward or done a clinic and say, well, what should my policy be? So I think it depends. I think a lot of research doctors, so my advice to anybody who's doing a PhD or a thesis is that the first chapter of your thesis should be a systematic review of whatever subject you're doing. So you can do a systematic review of trials, a systematic review of diagnostic tests, a systematic review of epidemiology, but a systematic review is a really important way to begin your thesis or your research project, because then you'll know everything about that topic before you start, everything that's been done before. And so it avoids duplication.
Okay, there is another question. What is the impact of publication bias in systematic reviews nowadays? Is this a phenomenon that diminished or increased during time? What are the weapons that we have to fight it?
Okay.
And are they effective?
I think the answer is we have the weapons. We now have much greater ability to search the literature, much greater power to find things like unpublished theses. We've got a great number of databases. The truth is that if you do a Cochrane review with the Cochrane stroke group or with another Cochrane topic group, they will use those tools and they will have a specialized register of trials that will have been compiled and can then pick out the information relevant to your question. I have to say that quite a lot of systematic reviews that get published don't necessarily use those tools. So there's always an advantage to trying to work with a Cochrane group if you're doing a systematic review, because they're using those tools. So the tools now exist, but they're not all used as much as they might be. But
another question, Peter. As you said, it takes a little bit time to get to your goal from the systematic review. So that can we check up the forest plot and assess the evidence through it? That's a problem. Many people think that just looking at the forest plot is all.
I think the answer is it helps you to understand why they've concluded what they've concluded, but it isn't the answer. It's the context. So in the example of the comparison of different regimes for glioblastoma, you know, on the one hand, you had chemotherapy having possibly a small effect on survival, but increasing thromboembolic events. And so you could look at those two forest plots and say, well, which is the more important? And it's the overall conclusion, the context that tries to weigh up the benefits and harms that you will see summarized in the forest plot. So I think it's important to understand what forest plots are and what they can tell you, but what they can't tell you, which is the broader clinical question and balancing up the risks and benefits.
Okay, a question from Sardinia. Who decides and how? What are the relevant topics of a Cochrane reviews?
Oh, that's a great question, because a Cochrane review is a lot of work. And in the beginning of the group that Stefano and I have worked on, the stroke group, we were very enthusiastic. We said, yes, if you want to do a review, yes, you should do a review, that's fine, any topic. But now, because there are now a lot of Cochrane reviews in stroke, 200, and it's important that we restrict the work, because there's a lot of work to be done, both by the individual person writing the preparing the review, but also for the editorial team who've got to check the review and support the development of the review, we need to focus on clinically important questions. And that means questions that will have an important impact on clinical practice and on patients' well-being. And so that there is a kind of priority setting process within the Cochrane Stroke Group and with other groups to try and make sure that if somebody proposes a new review, that it's discussed and the decision is made, is this sufficiently high priority that we will support the development of this review or not? And some reviews are trivial because you know that there's no evidence and it's not worth bothering with, or it's not a really important question. So I think it's the answer to your question is for Cochrane reviews, most editorial groups have a specific process to decide whether a review is a high priority. And what you'll also have is some reviews are quite high priority, but it might be a higher priority to update another review. So for example, in the context of COVID-19, there are now quite a lot of trials of anti-inflammatory agents like tocilizumab. And it's really important to keep the reviews of things like tocilizumab up to date. So as each new trial becomes available, trying to decide, you know, or in the context of renal disease, the anti-diabetic drugs, the SGLT2 inhibitors have effects on heart failure, on diabetic kidney disease, as well as diabetes itself. And so if there's a Cochrane review of SGLT2 inhibitors for diabetes, that really needs to be kept up to date because there's so many trials going on at the moment. Whereas some old treatments that, you know, are absolutely standard, like, as I say, aspirin for stroke, you know, that doesn't need to be updated. So that it might be important to get an existing review updated rather than do a new review of an unimportant topic. So that needs to be balanced up too.
Okay, the next question is about what to do in developing countries where there is a large patient population, but conducting a trial is often cumbersome due to lack of resources or patient compliance. How to effectively use the tools in Cochrane Library to obtain a considerable patient outcome in such a scenario?
Okay, that's a great question, and something that I think is very, very important, because in countries where health resources are limited, some of the things which appear in Cochrane reviews may be very difficult to implement. Having said that, there are quite a lot of Cochrane reviews which are based on trials which have been done in resource limited settings. So there's been trials in Ebola virus, there have been all trials in malaria, trials in SARS and MERS and all sorts of things. So there are trials that have been done in the sort of setting that you're talking about. And you're right that it's Vignesh, I think his name is that the resources are limited, but that doesn't mean that trials are impossible. The lesson is that trials have to be simple, they have to be efficient, they have to collect only the essential data. So for example, a big problem in low and middle income countries is motor vehicle crashes. And that's a big cause of mortality in South America, in Africa, in Asia. Many people die in car and motor crashes. And so bleeding from trauma is a big problem. And so the crash trial evaluated the tranexamic acid, a low-cost treatment for the treatment of trauma, bleeding due to trauma, and it's a lifesaver. And so those trials were done in low-income countries and tested a treatment that was important for people working in trauma in low-income countries. And then trials of tranexamic acid for women in labor to try and prevent postpartum hemorrhage. Again, done in low-income countries, Pakistan, Nigeria. So I think the world is making it possible to do trials in low-income countries. And actually, in a funny sort of way, Britain is a kind of low-income country. You know, because our health service is publicly funded, we have to do research in as simple a way as possible so that busy doctors can actually do the research. The recovery trial, for example, testing different treatments for COVID-19, has recruited 38,000 people from Britain only, from 177 hospitals in Britain. It's been simplified to the absolute maximum. And that's made it possible to recruit much larger numbers of patients than any of the trials done in America, which is a very wealthy country. So I think the lesson is, if you keep the trials simple, you can do it. And I would urge you, Dr. Vignesh, if you do a Cochrane review of a trial of an intervention that you think is important in your country, and you find that there isn't enough evidence, that is a really good way of saying, okay, there needs to be a trial in this country of this treatment. And so a Cochrane review is often a good way to promote the idea of doing a trial. And then if you've got an idea for a trial from a Cochrane review, you may be able to raise the money, or may be able to design the trial in a sufficiently simple way to make it possible.
There is a question from Maria Grazia Celani. Would you recommend and trust more than one head-to-head big trial or a network meta-analysis to give an answer to the efficacy and harm of more than a drug in a disease like multiple sclerosis, for instance?
Okay, Maria Grazia. Well, that's, again, it's a little bit difficult. Head-to-head comparisons of drugs that have commercial potential are difficult, because you need to get, if you want to compare drug A with drug B, pharmaceutical company A needs to supply the drug and pharmaceutical B needs to supply their drug, and then they're not going to be too happy if they're paying for a competition with their rival drug. So there's, if you like, a practical difficulty in persuading drug companies to actually do that. But that's certainly what we had tried to do in the UK with a large-scale multiple sclerosis trial of beta interferon. The government wouldn't pay for it. So the short answer is, in practical terms, a network meta-analysis may be the only option to try and estimate what the balance of risk and benefit for different treatment options is for something like multiple sclerosis. It's not ideal, but it's better than no formal comparison at all.
Okay, I don't see any more question. Kathy, do you see any more question around?
No, I don't see any more questions. So perhaps if there is anyone that has a question, you could also raise your hand and we'll let you speak directly online. And if not, then we will go to our conclusions. And so this is really proving to be a wonderful way to bring people together for a learning exercise.
Yeah.
And it makes, we don't have to travel. It's lovely to travel as well, but this is really a great...
But no pasta, no red wine afterwards.
I know.
Oh.
We will save that for the next time. Red
Yes.
wine and pasta, we promise. Anyone who wants to come, we'll organize an evening.
And cake, always cake.
Cake.
Many thanks,
Thank you,
Peter.
Peter.
Okay.
Thank you to
Thank you.
everyone
Bye,
who
bye, bye.
participated.
Bye.
Thank you very much.
Bye.
Bye.